years. He also worked in an aortic unit in UK for quite some time. He's involved in open and endovascular aortic work in Calicut Medical College to some extent. So he is the first speaker. But before we go on to session, Nilandan sir, can you introduce the topic and say a few words from your experience about aortic surgery in India and give an overview of abdominal aneurysm? Over to you, sir.
Thank you, Sunil. Thank you, Sunil. As Sunil said, when I started aortic work, there were very few surgeons who were doing occasional aortic aneurysm surgery. And during those days, we didn't have enough of investigational tools like what we have today, like CT, DSA, all those things. And we used to have these cassette changes for the aortogram. And we started doing, I did my first aortic aneurysm open surgery in 1985. And then slowly we, in Chitra Institute, and slowly we built up the aortic program in Chitra. And by the time I retired from there, we were doing around 90 to 100 aortic aneurysms per year in Sri Chitra. So probably that was the first vascular or aortic surgery department in India. And I'm very glad to see that many of my students and juniors have taken up aortic surgery in India, and it has become quite a common surgical procedure. I still like to operate. I still operate. Last 3 days, last 10 days, I have done 3 aortic aneurysms, 2 emergencies like an ruptured abdominal aortic aneurysm, then a acute aortic dissection, and then a UR for a AAA. So I think the aneurysm surgery is picking up. I am very glad to see that my juniors are doing it. And this type of webinar, I think you should educate the people. Not only the layman, even the doctor should be educated that the abdominal aortic aneurysms are fitting bombs in the abdomen, and they should be referred to, once it is diagnosed, should be referred to a vascular surgeon and vascular center where it can be operated. Sunil, okay, you can take over now.
The first speaker is Dr. Chandrasekharan. He works in Calicut Medical College as he's in charge of vascular division of in Calicut Medical College, and he is a assistant professor of surgery, and as well as he leads the vascular division of in Calicut Medical College. I think Chandru, are you there?
I think he's online, sir, but I think he has requested me to share his talk, which is recorded. So is the screen on, sir?
Yeah.
Is audio coming?
No, audio is not coming.
Audio is there, but volume is very less. If it's there, we can make presentation.
Okay now?
Good evening, everyone. This part of the session is essentially about evaluation and decision making with regard to abdominal aortic aneurysms. So when you are a clinician post with a patient who is potentially likely to have an abdominal aortic aneurysm, what are the questions that you would like to be answered? First and foremost, how do I know that I'm dealing with an aneurysm of the abdominal aorta? Once I make my diagnosis, the patient needs intervention. If so, what is the form of intervention? And how soon does he or she need intervention? And last and foremost, where do I send the patient? Once I've decided that my patient needs intervention, where do I send the patient? So these are the questions which you would like to get answered. And this is what we will be looking at the next 8 or 9 minutes. So by definition, an aneurysm is a localized dilatation of any arterial segment to more than 1.5 times its normal diameter. Less than that, we tend to call it as an ectasia and not as an aneurysm. Now, ectasias are different from aneurysm in that they are physiologically all right and do not require any special attention. You can just keep them on follow-up maybe. Whereas aneurysms are a pathological entity and requires special attention. So essentially, if you take the average diameter of the abdominal aorta to about 2 centimeters or so, and if you multiply by 1.5, you're talking about a diameter of 3 centimeters, then beyond which you tend to call it as an aneurysmal abdominal aorta. Now, most of us would be aware that it is the infrarenal portion of the abdominal aorta that tends to become aneurysmal. By and large, atherosclerosis and hypertension are the predominant causes. Occasionally, you tend to have infections and trauma, which tend to cause abdominal aortic aneurysms. Of the risk factors, smoking is a reversible and preventable risk factor, but the other predominant risk factors like age more than 65, male sex, and a strong family history are not preventable. Now, how do these people actually present? Most of them remain asymptomatic for a significant period of time in their evolution till they actually start getting symptoms. So this category of asymptomatic patients in the Western countries, they are normally picked up by robust screening program. We in our country do not have the screening program. So these patients are actually picked up when they get an ultrasound or a CT scan done for some other unrelated pathology. When they do present, they tend to present with pulsatile abdominal swellings or as thromboembolic disease. Essentially, thrombus within the aneurysmal sac tends to either occlude the aorta itself or it tends to get showered down the distal extremity, presenting with lower limb ischemia. Rupture is by and large the most fatal presenting pattern. And once you have an acute rupture, it's a very fatal condition. And even in the best of centers with the best possible treatment, the mortality and morbidity still remain very high. So the whole gist of everything about abdominal aortic aneurysm is to prevent acute ruptures as far as possible, identify patients with abdominal aortic aneurysm early in their course of evolution before they actually go in for rupture, and then treat them accordingly. So how do you investigate and how you confirm your diagnosis? The best investigation and the simplest investigation you can do is a plain and simple ultrasound of the abdominal aorta. Now, any radiologist with good competence in vascular imaging will be able to do this for you. The abdominal aorta is very well imaged by using an ultrasound. You don't need any extra fancy investigation to confirm your diagnosis. Also, you will have a rough assessment about the size of the aneurysm as well. So it is because of these qualities of an ultrasound of the abdomen that USG is the preferred investigation for most screening programs in Western countries. And even here, if you want to keep your patient on follow-up, that is, if you decide not to do any intervention, you just want to see if the aneurysm is increasing in size or not, an ultrasound is the preferred investigation of choice. Once you've made your diagnosis, and then if you want to plan treatment, you need some form of cross-sectional imaging. By and large, most centers would resort to a CT angiogram. But if you have a patient with a compromised renal function, occasionally you might have to resort to an MR angiogram. A lot of information like the length of the neck of the aneurysm, the angulation of the neck. Neck essentially means the portion of the aneurysm between the renal arteries and the top end of the aneurysm. So the length of the neck, the cross-sectional diameter of the neck, and the angulation, these are all important information with regard to treatment plan. The other information that you would like to get is basically the access vessels, what is the extent of the aneurysm, the nature of the iliac vessels and the femoral vessels, how large are they tortuous and things like that. So all the information are actually obtained by cross-sectional imaging. So it's very essential for treatment planning. So at this juncture, it would be worth mentioning that preferably, actually these investigations are best done, especially the cross-sectional imaging is best done at the center where the patient is actually going to get the treatment done. Because many times we see patients referred to such centers with cross-sectional imaging, sometimes very poor quality images, and then the image has to be repeated in the treating center. So it is very superfluous and some amount of money is being wasted in that way. So if we have the luxury of doing that, preferably cross-sectional imaging is better done at the center where the patient is actually going to get the treatment done. But if there is some confusion in the ultrasound, it's always wise to get a cross-sectional imaging and confirm the diagnosis. But the important thing for practical purposes to confirm the diagnosis, ultrasound is all that is required. As part of the work, important thing is cardiopulmonary risk assessment, because essentially it decides whether your patient requires treatment and what potential form of treatment will be offered. Now, a basic static cardiopulmonary assessment would include an echocardiogram, an echocardiogram, and pulmonary function test. You can use cool modalities of dynamic assessment, like walking or climbing a flight of stairs and things like that. But most aortic centers would resort to a formal CPET scoring test, with cardiopulmonary exercise testing before embarking upon any form of definitive treatment. So essentially in this scoring system, the patient is asked to climb onto either a treadmill or a bicycle, asked to do some minimal effort, and the pre and during effort assessment is made based on a number of parameters. So what you essentially look at is the anaerobic threshold, the VO2 max, the ventilatory equivalent of oxygen and carbon dioxide, and some other parameters. By and large, the most important is the anaerobic threshold. Usually what you're looking at is whether you have an anaerobic threshold of more than 11 or less than 11. 11 is an arbitrary cutoff. Beyond 11, your patient should be okay for an open surgery, and less than 11 means you basically have to consider some other form of intervention. Now, who to treat? Once you have confirmed your diagnosis, do all of your patients require treatment? The answer is no. So two things have to be considered. One, is the patient symptomatic? And second, what is the size of the aneurysm? So if the patient is asymptomatic, that is, if they are incidentally picked up at the program, and if you find that the size is less than 5.5 centimeter, the chance of them developing pre-rupture is very, very low. So the amount of benefit you're going to offer, you will be able to offer by your treatment is very, very low. So this category of patient can essentially be kept on follow-up by serial ultrasounds every 6 months to see if there is any disease, then they require treatment. But otherwise, they can kept on follow-up treatment. The second category of patients is those who are asymptomatic but have an aneurysm size of more than 5.5 centimeter. Now, this category requires treatment because their chance of free rupture is very, very high. So even if they are asymptomatic, they should be offered prophylactic treatment. Any patient with any form of symptom requires treatment. There is no doubt about that, and size doesn't matter in that particular scenario. So whether it be pain, whether it be local compression, or whether it be an aortoenteric fistula or thromboembolism, irrespective of the symptom, these category of patients require treatment irrespective of the size as well. So how to treat? Now, the gold standard of treatment has always been and is still open aortic surgery. So essentially, you put the patient to general anesthesia, open up the abdomen, cross clamp the aorta, and then replace the involved aortic segment with a prosthetic graft. Typically, the procedure takes about 3 hours or so. In most centers, but some centers, expert centers, you can get away with about 2 hours of open surgery. And then the patient usually remains in hospital for maybe about 7 to 10 days, out of which about 2 days will be in ICU. I believe in the next session, RC sir will be elaborating on that in detail. On the right-hand side, you can see the newer treatment modality, which is endovascular aortic aneurysm repair. So essentially, you don't need to open up the abdomen. With 2 small incisions in the groin, you can access the femoral vessels and deploy an aortic stent into the aorta to reinforce the abdominal aorta from within. So the image which you see on the right-hand side is basically an EVAR done by our very own Neelakantan sir and Dr. Vineet at Jubilee Mission Medical College, Thrissur, about 2 days back. And I believe the patient is doing extremely well as of now. So this is how they look after the procedure. On the left-hand side, you can see somebody who has had an open surgery, and on the right-hand side, you can see somebody who has had an endovascular repair. So going by this, you might think that the decision making is very easy. If your patient has got the luxury, you should send the patient for EVAR. However, that is not entirely true. Endovascular repair, even though it has got a lot of advantages like early recovery, shorter hospital stay, and reduced operative mortality and morbidity, there are several disadvantages as well, which is in a country like India, where finances often decide what treatment modality your patient should be taking in, EVAR is basically about 6 to 8 times more expensive than open surgery. So it has to be chosen very carefully. The potential for re-intervention, especially after the first 2 years or so, is significantly more in endovascular repair than open surgery. Essentially, open surgery is a very robust treatment, except for the immediate post-operative mortality and especially morbidity, which is relatively high compared to EVAR. The long-term results and the number of repeated re-interventions are very, very minimal with regard to open surgery. And not all patients can undergo endovascular repair. Several anatomical prerequisites have to be fulfilled before you can decide whether your patient can actually go in for EVAR. I believe Dr. Nandan in the next session will be describing that in detail, so I'm not elaborating it at this moment of time. So essentially, in summary, the factors you consider before deciding on whether your patient needs an open repair or endovascular is first and foremost age. If your patient is young and fit, there is no doubt that they should be offered open surgery because they've got a longer lifespan to fulfill. If your patient is old with a limited lifespan, foreseeable lifespan, then EVAR can be considered. Second is physiological status, which in most centers satisfies the score. If your patient is unfit for open surgery, either because of a poor physiological status or maybe because of a hostile abdomen where they had previous surgeries and all those things, then you can consider endovascular repair. But otherwise, if your patient is physiologically fit, young, open surgery should be the treatment of choice. Then anatomical consideration, as I mentioned earlier, and in our country, financial considerations have to be put into the picture because, like as I mentioned earlier, EVAR is, whatever said and done, a costlier treatment option. So that has to be taken into the consideration before deciding upon the treatment planning. Now, the big question is where to refer once you have assessed all this. Where do you refer your patients? Now, two things must be considered, and they are very important. One, patients often do very well when they get operated in high volume centers where these procedures are done routinely than in centers where they are done maybe once in a while. So it is very important to identify and refer the patients to your regional center, which does the maximum number of such cases. Second is, in an ideal center, they should be able to offer both open and endovascular options, and preferably the team should be led by a vascular surgeon who can decide which treatment modality is best suited to your particular patient. So that has to be kept in mind. Unfortunately, we don't have a system where we know where we can identify and how we can identify such centers. I am happy to let it know through this presentation that under our Vascular Society of Kerala President R.C. Srikumar sir, VASC has taken up an initiative to publish a list of such regional centers all over Kerala, which will basically facilitate easy referral. Maybe the referring person can communicate with the surgeon in that center and then do the referral. So you will know upfront which centers are capable of doing such procedures and which are the ideal centers, and this will add a lot of benefit to improving the patient care. So I'm stopping at that, and I hand over the session to the remaining presenters. Thank you.
I think that was a good overview of how to evaluate and how to decide on what treatment option should be given to the patient. Is it open surgery or EVAR? Next speaker is Dr. Srikumar. Actually, he is a VASC president. He is presently working as the professor at Trivandrum Medical College, also heading the vascular division at that medical college. He was previously head of vascular division at Sri Chitra Institute of Medical Sciences. I'm really happy to say that probably he is one of the surgeons who has done the maximum number of open aortic work in the government setup. He has a lot of experience in open aortic work, both in occlusive disease as well as aneurysmal disease. And he is ideal to take on this topic on open aortic surgery and how and when, etc. So over to you, sir, Dr. Srikumar.
Am I audible?
Yes, yes, yes.
Okay, thanks Sunil for the nice introduction, and very happy to present this topic. It's a very important topic for the surgeons. Particularly, I am presenting my topic on to my guru in aortic surgery, Nilakandan sir, who taught me the aortic aneurysm procedures. In fact, working with him gave me a lot of confidence to do aortic surgery from the day one itself from medical college at various levels. So it's a wonderful experience to work with him, and welcome Dr. as Chairman VASC, I welcome Dr. Nandan, our UK friend, to share his experience. So Chandrasekhar has given a nice introduction regarding when to how to select and when to operate, and how to operate, how to choose the best options. So yes, by definition, it's I'm concentrating more on the infrarenal aortic aneurysm, where the aneurysm starts just below the renal arteries. This is the normal aorta, and this aneurysmal sac. The normal iliac, the aneurysm starts just before the renal arteries. That is classically called infrarenal aortic aneurysm. There are variants of abdominal aortic aneurysm where aneurysm will affect the segments parallel to the renal arteries or more above to it. These are different variations of abdominal aortic aneurysm, but most of the aneurysms are type this one, where it's confined to the infrarenal segment of the aorta. That's commonly called as So we have studied almost 8-year experience in Srijitra regarding the different modes of aortic aneurysm presentations and repair. And our mortality is, overall mortality is less than 3%, in spite of it's a high volume center. So that's a good result for example, for the aortic aneurysms. And that gives a very good hope that if you do it properly, these patients will have a normal life, almost just like a normal life after this. That's a very important aspect of aortic aneurysm repair. In fact, that's a message of today's session also. So as Chandru said, all patients doesn't require surgery. There are definite indications to do it. But the most important thing is if any patient has to do it, the open option is the best option compared to EVAR, because long-term morbidity, long-term problems are very, very less compared to open treatment than the EVAR. Then as Chandru said, any asymptomatic aneurysm more than 5.5 centimeter in the male and more than 4.5 centimeter in the female, average you can take it as 5 centimeter, has to be operated. And there's a group of patients having a symptoms we call symptomatic aneurysm, like abdominal pain, backache, impending rupture, or arthroembolus in the thrash foot. These patients has to undergo surgery. There's another group where the complications of aneurysm due to fistulas into duodenum, or it's any other fistulas, and some patients may have congestive cardiac failure due to a high venous fistula also. That's a cavern fistula also. That's also an important indication to operate. And if we put the patient on follow-up, ultrasound follow-up, and if the size is increasing more than 0.5 centimeter over 6 months or more than 1 centimeter per year, that again is an indication for undergoing surgery. Then other rare signs are crescent sign, where fresh blood is bleeding into the hematoma. And if you take a CT, there is a hypodense area seen under the hematoma. That's called crescent sign. That's a definite indication because that's a sign of impending rupture. Or there's an aortic calcification. If you look at even the X-ray, the calcification is very, very irregular with a huge aneurysm that also has to be operated. Sometimes when you open up, you can see that blebs in the aorta. These are blebs in the aorta. That's another indication. And if the aortic wall is irregular also, that is needs to be. So it's very important to prepare the patient, because the outcome, good outcome, depends on how meticulous we are preparing the patient. A bowel pressure has to be done in the preoperative phase. But the most important are the coroners and renal workup, because most of the patients, we lose the patients when they have a compromised coronary or renal function. And most important cause of death all over the world in any center is myocardial ischemia. So we should have a definite understanding of the coronary status of these patients. We can do either a stress echo or a coronary angiogram, or some centers will do 8 minutes or 10 minutes walking fast walking test and the change in the pulse rate and the blood pressure. That's also enough for some centers. And the renal parameter, serum creatinine is mandatory, because that's the second commonest cause of death all over the world. So this is very important to prepare the patient. Then blood should be arranged adequately. These 4 to 5 units of blood should be available to your disposal. That's also important, and we have to get a good consent regarding the procedure, because it's a very major procedure going to for the patient. And the consent should explain there's another option called endovascular. As Chandrasekhar said, is a costly or financial constraints, but patient should know that endovascular option is available for this surgery. So in principle, there are certain things to be followed up when you're doing a surgery, because we are clamping the aorta during the procedure. So clamping is very, very important, and release of the clamp is also another important factor. If you do a clamp over the renal arteries, if you maintain it for more than 35 minutes, there's high risk of renal ischemia leading to post-op complications and renal failure. And another principle is, if the iliac artery size is more than 2 centimeters, even though it doesn't show any thrombus, it is better to repair that iliac artery also. Then the third question is, do we reimplant the inferior mesenteric artery? If it's a young patient a long time ago, better to reimplant it. Other definite indications are, when we open the artery and see that opening of the inferior mesenteric artery, look at the back bleeding. If the back bleeding is very good, that means there's a very good collateral between the inferior mesenteric artery and the superior mesenteric artery. Then we can straight away ligate the inferior mesenteric artery. If the back bleeding is very poor if circumstances are good and you have facilities to do, we can check the stump pressure of the inferior mesenteric artery, and if it is 40 or less than that, the normal blood pressure, again we have to reimplant it, considering the possibility of a poor collateral between the superior mesenteric and inferior mesenteric artery. And any patient who's undergone previous collateral section with major vascular tie-up, again, it is better to reimplant the inferior mesenteric artery. Otherwise, if there's a good back bleeding or the stump pressure high or there is no previous surgery, we can straight away ligate the inferior mesenteric artery from the aneurysm itself. And fourth principle is the surgeon should have, the surgeon and the team should have a very good relation with anesthesia team, because the 50% of the outcome is decided by a good anesthesia. They should know the procedure. They should move with the surgical team during clamping and declamping. So these are things to be considered before we are into procedure. The procedure can be done under general anesthesia preferably, and post-op analgesia can be provided by epidural. But there are a group of patients where GA, contractile GA is not ideal thing. In these cases, epidural alone can be used to do the surgery. This is a prolonged procedure, and our back is also, spine is also important. So ideally, we have to position the patient, and we should make sure that we are quite comfortable with the procedure. That's also important. And there should be a good discussion between the surgical team in themselves, the surgeon, the assistant. Particularly, you're starting the program in a new center. We should have a good discussion with the surgeon and the assistants and the nursing team, the scrub nurse team, because they also should know what the procedure is. And definitely there should be planning between this anesthesia team and the surgical team, particularly in a new center. And another thing is the instruments are very, very important for doing aortic surgery. And once the aorta is clamped, you cannot run the scrub nurse. You can ask the scrub nurse to run away to get this thing. So make sure that before clamping, those instruments are available on the table itself. That includes a good number of aortic clamps, a good needle holder, vascular thumb forceps, and a good scissors. They should be available on table, and you should make sure that's available before clamping. And sutures is also very, very important. We had funny experience where nursing staff have cut the double arm sutures, finding 2 needles in one suture. So this should be informed. There should be adequate number of sutures. Should be mantled to the umbilicus. So this is ideal. I'll come to it later, but it's a proper incision. And there's a new concept is coming up. In fact, not a new concept. I have seen Nilakanta sir operating 1 or 2 cases during his tenure years back, but it didn't get much momentum. But now it's getting popularized, because this is ideal for patients who have very poor lungs, particularly COPD patients, where you can avoid general anesthesia and do a transverse incision just above the umbilicus. So once the abdomen is opened, either through midline or intraperitoneal or a transverse incision, the approach to aorta is only 2 methods. One is transperitoneal, second is retroperitoneal. Transperitoneal is you mobilize the duodenum complete, the 4th part of duodenum towards the lateral aspect, and divide the ligament of Treitz. Then you go up to left renal vein and identify the aorta. That's the method. This another method is even the midline incision. If that duodenal part is a lot of undulations are there, then you can do is you can mobilize the left colon from here, so that the colon can be rotated medially, so that aorta can be exposed. This gives some advantage, so that you can expose the suprarenal aorta also to some extent, particularly pararenal and aortic aneurysm. This gives some advantage. Transperitoneal approach is the commonest method for many surgeons to do, and this is the method every surgeon should know if you are planning to do aortic surgery. And these are the ability to explore the whole of abdomen from the left renal arteries to the iliac arteries. And importance is, if this, and another advantage of this is you can expose both iliac arteries for the iliac artery repair. And sometimes you have there may be some aggressions. This is the classical midline midline transperitoneal. This is a ligament of Treace, the fourth part of duodenum. You start the incision from this point up to this iliac artery so that it will expose the complete aorta. This is the left renal vein. The left renal vein is there. This left renal vein is there, and both iliac arteries are exposed completely. It's a classical midline transperitoneal approach. Is popularly used for aortic aneurysm repair. This is aorta is exposed. This is one other thing is if you're operating a male patient, there's a nerve agency situated here, a young patient. So it's better not to dissect out here that may damage the nerve agency and producing chronic, it may produce chronic impotence. So in the cases, you can identify the ureter, stay below it, open the peritoneum and dissect out the common iliac artery, internal iliac artery, and external iliac artery. This is, and you can put a graft there so that you can avoid the impotence in these patients. So the importance is we have to identify 4 veins, and we have to identify these 4 veins. Damage to any of them, it produces severe bleed during the procedure. The most important left renal vein. Left renal is the upper point of the dissection. You have to identify the left renal vein, tape it and lift it. That's the most important part. Then we come to right side, the inferior vena cava. It's very close to aorta. You can have a straight dissection here, a sharp dissection to keep the left renal vein away from that aorta. The other thing is that the inferior mesenteric vein is there, that also has to be dissected out. Then one of the most dangerous vein of the dissection is left common iliac vein. When you're dissecting a left common iliac artery, make sure that left common iliac vein is not injured. Once it is injured, we'll have a tough time to deal with. Now, once the dissection is completed, give heparin to the patient. I can ask the anesthetist to give heparin 1 ml per 100 units per kilogram per body weight. Then we have to prepare for clamping. Clamping is itself a process, and we have to tell the anesthesiologist that we are proceeding with the clamping and make sure that the ECG is normal. And before prepare the clamping, make sure that the graft is available and suitably available. Why the graft is important? Because now most of the grafts available are collagen coated grafts. Before that, there's a plain grafts are available which needs pre-clotting, and for the pre-clotting we need non-heparinized blood. So before ask the patient, ask the anesthesiologist to give the heparin, you have to make sure that you have a plain graft or a collagen coated graft. And once a collagen coated graft, or if it's a plain graft, you can take 10 ml of blood, the non-heparinized blood, and use it for the pre-clotting. Otherwise, you can straight away go to heparinize the patient and wait for 3 minutes for that so that heparin can act. And another thing to be careful is the myocardial ischemia. Myocardial stress and strain, which can be reduced by the blood pressure by 25 to 30% of the injection time, so that the complications are less. And always check the instruments, as I said earlier, and confirm availability of this. So this is heavily exposed. We take all precautions and then start clamping. Clamping should start from the lower aspect, because if you apply clamp on the upper side, this debris may lose into that, may be released into that lower limb that produces ischemia and other embolus also. So ideally, you put 2 clamps in the iliac arteries first, then go to the upper aortic clamp. So once the upper aortic clamp is placed, then open the aorta and remove all the clots, thrombus everywhere inside, and make sure that this is the lumbar veins, lumbar arteries. So close all the lumbar arteries, the inferior mesenteric artery, to avoid back bleed into the sac between the graft and the aortic wall. Then once the procedure is complete, then declamping, which is more dangerous than the clamping process. So again, declamping needs some preparation. Ask the anesthetist to increase the BP and fill fluid, because when you declamp the patient, then we drop in BP. That sometimes it can be dangerous also. And you have to anticipate acidosis also, that has to be addressed. And heparin reversal, if anesthetists agree, you can do it with a protamine, but many centers are not doing any reversal. So once the repair is completed, it may appear like this. This is the normal aorta, this is the normal aorta, and you put a tube graft between these two. This is the way it's an infra aortic aneurysm after repair. And on this side, if you are using a trouser graft or a Y graft, it will appear like this. So always please remember that aorta is a retroperitoneal organ. So better to close the retroperitoneum anterior to the aneurysm so that the graft will make the post. The retroabdominal approach is ideal for patients having a hostile abdomen, previous surgery, radiation, etc. Or when you have a patient a concomitant abdominal malignancy like a gastric malignancy or chronic malignancy, better the retroabdominal repair of the aortic aneurysm. There are a lot of advantages like less pain, patient will be having early peritoneal activity, bowel activity, and if you have a pararenal aneurysm or a suprarenal aneurysm, this gives you better advantage. But disadvantage is approach to a right iliac artery is very difficult to do a retroabdominal approach. This is a retroabdominal approach where aorta is exposed here. You can see the spleen here. So technique is almost same as the that open surgery almost same, but you approach the lateral aspect. Patient keep to the lateral aspect. Incision you plan it more lateral and go for the left renal artery first. Then we can divide the left renal vein if needed, but make sure that no other vein is ligated like gonadal phrenic vein, which will take care of the renal backflow if the renal vein is ligated. So once the repair is complete, we should be very careful about post-op complication. The most important is myocardial infarction, which occurs almost 15% of patients undergoing aortic aneurysm repair, and other complication, renal failure, which occurs about 5 to 6% of these patients. So these two things very careful, and this can be avoided by good preoperative screening and intraoperative mechanisms and post-operative care. If the patients have a renal problem or if the kidneys or renal arteries are clamped for a long time, there are measures to protect the renal arteries, renal parenchyma. That is, one thing is always try to keep the clamp below the renal arteries. Even though there's a lesion above to it, put a supra clamp, do the proximal repair, then immediately go down and clamp below to it. That's one method. And still, if you take more time, you can apply ice packs above around the kidneys. And if you reduce temperature by 1, it will reduce 7% renal metabolism. That's the second method of protecting kidneys. Still, if you have problems, then you can infuse saline with mannitol metoprolol through the renal arteries using Nahara position. That also the kidneys are protected. There are a lot of complications, but remember that even though these complications, the overall complications are very, very less compared to rupture of aneurysm. So they should be offered a surgical repair if any patient has an aortic aneurysm, particularly the huge aneurysms, and if they can survive surgery. The most important other complication is graft infection, because even though the incidence is less, but if it occurs, that's almost equal to death. So there are patients who are very rarely we have patients we had with graft infections. We have done a study and we have seen that graft is very, very less, but overall outcome is very poor. This is a patient where undergone aortic aneurysm repair, develops a huge infection there. But after that, we replaced the infernal segment with a vein conduit. This is 2 femoral veins taken from both sides. We made it to a V-shape Y graft like that, and we put the graft across it so that we can avoid a graft infection in this patient. Risk can be accessed by various methods. There are a lot of scoring systems are there, customized probability index or a modified probability index or a VPOSM. But the most important is Glasgow aneurysm score, where look at the preoperative shock. If there is rupture, the shock is there, the result is very poor. And look at evidence of myocardial infarction or renal impairment, because these two are the factors to decide the most outcome. So the message is very clear. Aortic aneurysm is a surgery which is to be done of all patients, and every physician has to look for aortic aneurysms. The importance is, this is from the Rutherford essays, non-repaired or non-treated aortic aneurysm is equal to a stage 4 malignancy, and a treated one is almost equal to a inguinal hernia. So you are converting a patient 6 months outcome to 15-20 years normal life. That's the most important. And even with the new techniques of EVAR, with all the technical advancement, surgery is the best option due to various reasons. And there are a lot of studies comparing the screening methods for aortic aneurysms in the high-risk patients, old age patients, but none of the studies is not cost effective. But we should have a high suspicion of these lesions, and the treatment in almost all centers is less than 5%. So when you have a patient with chronic backaches, hypertension, abdominal pain, or any things, do an ultrasound at least. Identify the patient is for aortic aneurysms and refer to vascular surgery. That's very important. Once again, I thank you all for the patient hearing and presence here. Thank you very much. I give back to Sunil. Thank you, Sunil.
Thank you, RC sir, for that great talk. Actually, it shows the experience of aortic aneurysm surgery that you have been all these years. Before we move to the next topic, which is we have the guest speaker for today, going to speak on an important topic. We will have Siddharth to announce the winners for the last session.
Yes, so we had a good participation for the quiz in the last session on peripheral artery disease, and the winners were Dr. Gopika Jit from Amrita Institute of Medical Sciences and Dr. Jenimol Varghese from Wayanad Institute of Medical Sciences. So both of them win prize money of rupees 2,500 for this and from VASC, and we also encourage all of you who are attending today's session to participate in the quiz for today's session, which will be published as a link after the next talk. So over to you, sir.
Okay, next we have our guest speaker, Mr. Nandan Haldipur, who works as a consultant vascular surgeon at Doncaster Royal Infirmary, UK. He is actually a good teacher. He teaches a lot of our postgraduates and all the VSI meetings and as a constant faculty at the VSI meetings over last many years. His topic is actually very important in today's context because he's going to weigh the options of EVAR versus open surgery and as well as share the experience of UK about the EVAR and the outcomes of EVAR in UK. Before I go to Nandan, I welcome Unnikrishnan sir, who joined a little late because of his commitment with VSI, who is also a leading aortic surgeon and pioneer aortic surgery in Kerala and all over. He's a well-known aortic figure in India. So with those few words, I welcome you, Nandan, to this meeting of VASC from UK.
Thank you, Sunil. The Vascular Society of Kerala is very dear to my heart because I've got lots of dear friends with very good memories in Kerala. So thank you very much for this invite. And over the next few minutes, I'm just
Mr. Haldipur, shall I put up your talk?
Yeah, I think you should do that. Is that okay? I'm trying to desk.
Is it visible?
Yes, it is. Can you go on to slideshow, please?
Yeah.
Okay. Thank you very much for inviting me and B for turning up. I'm Nandan Haldipur. I'm a consultant vascular surgeon at the Doncaster Vascular Center. And to give you a little bit of background for Doncaster, we were one of the early units in the UK to take up endovascular repair of aneurysms. So we have a reasonably vast experience and I want to share it with you. That's a view of our hospital and that's the view of our A&E. Obviously with COVID now, there's a lot of boarding up and all that, but one day we'll get back to this view. Next, please. Sid, next slide, please. So over the next few minutes, I'm going to tell you, because I understand that it's a mixed crowd, I'm going to tell you what are EVARs. And I'm going to talk to you about a little bit about patient selection for EVARs. The speakers before me, Sri Kumar and Chandrasekhar, have given you a nice background of patient selection, but I'll tell you a few specifics for EVAR. I'll talk you through the procedure itself, some of the complications, and then I'll tell you about our results in Doncaster. Next, please. So EVAR is endovascular aneurysm repair. It started more than a decade ago and is becoming a popular therapeutic modality for abdominal aortic aneurysm. There were several trials that justified the presence of EVARs, but however, it's very important to note a fact that has been emphasized by my previous speakers, that although in the short term, EVAR looks very attractive, once the patient is over the immediate post-operative period, the early advantage of EVAR is lost. And I'll explain that to you in a minute. there's a society called NICE in the UK, National Institute for Clinical Excellence, and they provide us with guidelines. And these guidelines are excellent. So whichever field of surgery you practice, I recommend you look up the NICE guidelines, because this is done by independent people who look up all the evidence, weigh it up, look at the cost, weigh it up, and tell you whether the procedure is effective, if it is effective, whether it is cost effective. So NICE published some guidelines about EVAR. There's lots of controversy raised, but then in the end, the guidelines have now been formulated and published. And even they say surgery is better as a therapeutic modality for treatment. However, there are some niche places where EVAR is beneficial. Next, please. So what is EVAR? On the left-hand side of the screen, you'll see the EVAR device. You see that, Sid, can you put the pointer on that thing, please? So if you see that, that's the graft at the top. And right at the top, the rocket-shaped thing that you see is what holds the device together. That's called the nose cone. That holds the graft together. Then you see the wire. That's the delivery system. So inside that are certain release wires. And this is the handle where the mechanism, the entire mechanism lies. So it looks like a tube that's loaded up. And on the right, you can see the various components of the graft. It's not one component. It is multiple components that the graft has. So if you come to the middle of the graft with the spikes, that is a graft with a suprarenal fixator. So you see those spikes, they have little barbs attached to them. So they go into the aorta and the barbs latch onto the aortic wall. Once they latch on, it becomes firm. And then you put in these other small components, which are called the limbs, to lie in the iliacs. So ultimately, if you come below the screen here, you will see that this is the intraoperative image that you have. And you can see the aneurysm that's lined by, on the right side. Yeah, if you see that, it's lined by an EVAR stent graft, the entire aneurysm. You can see above the renals, you can see some little dots above the renal arteries. Those dots are where the barbs have attached and the limbs extend into the iliacs. So the entire aneurysm is excluded, and that is how an EVAR works. This is the same graft that is in situ from looking at it from the lateral side, where you can see the spine as well. So as mentioned, you can see the surgeons operating on the left. This is one of the operations where you don't, although you look at the patient, you stare more at the screen while you're operating, and especially to make sure that the graft sits very precisely where you want it to sit. Next, please. So as my previous speakers have alluded, it's an expensive procedure, and with the expenses because of the kit, the graft, and all the equipment that you need. So you can see that's the theater, and you have imaging facilities in theater. You have the screens in addition to all the other things that you need for performing an aortic aneurysm, anesthetic help, support mechanisms and all that. But what is very important is an good image intensifier, which can give you good images. And here is a schematic. The cartoon that you see is of the EVAR device going in. You can see from left to right where the abdomen, you push it up, you push up the device, you park the nose cone near the kidneys, near the renal arteries. Then you inject some dye, make sure you're not covering the renal arteries, because if you deploy the EVAR and you cover the renal arteries, the patient goes into kidney failure. So you've got the top end needs to be perfectly positioned. If you drop it too low, it won't form a seal and you will develop leaks from there. And I'll explain leaks to you in a minute, but you need it to sit just below the renal arteries, like you see there. And then you deploy the body. Once you deploy the body, then you go on from the contralateral, in this case, the right groin, and you deploy the limb. And the rule of EVARs is you cover as much as possible. You don't cover as little as possible. So as you can see, the iliacs are covered right up to the internal iliac. You can see if you cover the internal iliacs, again, you'll have problems. So it's quite a precise technique of deploying the stent graft. Next, please. Now, you can see the advantages initially are very obvious. On the left, you see the patient who's had an EVAR, 2 small incisions, EVAR done. In fact, we do a lot of them percutaneously these days, and especially with COVID, we are doing a lot of perc. So you don't even have cuts. You just have puncture holes in the groin, and they take 1 stitch, if at all, or no stitches, steri-strip it, and the patient's done. Whereas with open abdominal surgery, you have a big cut across the groin, transverse or on the side, but there is a big cut involved. So straight away, there is a small advantage. Next, please. Now, once the EVAR is done, you check that the graft is in situ and things are okay. So the first scan that we get, we have a program to keep these patients in surveillance. And that is because at the end of the day, you've put a device into the patient. It's like a car. Every so often you need it to be serviced and make sure that things are going okay. Similarly, the EVAR device is a device and it can fail over time. So we have to have it under surveillance. And in Doncaster, we get an abdominal X-ray immediately after the operation. That serves as our baseline. After that, we get a CT scan, and this is what our CT scan shows. You can see the device in the aneurysm. You can see the iliac. This is a reconstructed image. You can see the renal arteries. Renals are well perfused, and there is no leakage of blood either at the top or through the graft or from the sides. So we're happy with that. Once we're happy with that, we then get abdominal X-rays and duplex scans, 6 monthly, yearly, and if all is well, yearly after. So therein lies a disadvantage. These patients need surveillance because a significant proportion of them have developed problems over time. Next, please. So again, this is post-op images that we do, and you can see the graft sitting nicely. Although I've taken, this is not, you can't, it's not in continuity because this is one slice of a CT on the coronal section. You can see the renals there. You can see the graft. You can see the graft sitting in the iliacs, and you can see it's opposing nicely against the wall of the vessel. So that means that the EVAR is sound and it is working well. Next, please. Now, the benefits, as Srikumar told you, the operative times are a lot shorter. So if the EVAR is very straightforward, you can get the patient off the table within an hour. We always have an anesthetist around, but because the insult to the physiology is not so bad, and blood loss is again minimal, and cross-clamping time is minimal, so the anesthetists are a little bit more relaxed with EVARs. The recovery, understandably, is a lot quicker. Our percutaneous EVARs go home the next day. If the patient is really fit and well, they've even gone home same day at night. There are disadvantages. It's not all rosy. Like I told you, specialist equipment is required. Lifelong follow-up is required because you're putting a device in a patient, and you will have late complications. I want to draw your attention again to this picture, and you see the precise placement there. You can see the nose cone going out and the barbs coming out to fix the device and the iliacs. Now, there can be various points of problems, which I'll bring you back to in a minute. Next, please. Patient selection. Whether it be EVAR, whether it be aortic aneurysm surgery, if there is anything that I have learned in surgery, the most important thing is patient selection. You select, it's your right patient for the right operation. Unless you really do badly intraoperatively, the patient does well. Okay, so it's very critical. Take a good history and examination. The history should be thorough. You should do one of the very important things in history is exercise tolerance. And we do a lot of investigations, cardiac profile, renal profile, pulmonary functions. But if the patient tells you that he can walk at least 2 flights of stairs without becoming short of breath, that means he has good cardiac tolerance. And that is one of our key measures. So generally, if I'm doubtful about a patient, or if my anesthetist is doubtful in Doncaster, we see all our patients pre-operatively by the anesthetist and during assessment. And if there's any doubt, we just walk with them 2 flights. And if they manage 2 flights, even if the echoes is borderline, we are confident in operating, and the patients do well. So in Doncaster, we get a CT scan. This is with contrast. Then you do, for cardiac investigations, all we do is an echocardiogram and not a stress echo. If the echo is poor, then we refer it to the cardiologist and then they take it. But if the echo is acceptable, we are happy. Then we do pulmonary function tests. Again, we check the FEV1, the vital capacity, and so forth. And then the patient comes with this information, the patient comes to what's called an MDT, multidisciplinary team meeting. In the MDT, you have the vascular surgeons, not just one surgeon. We have vascular surgeons, we have radiologists, we have the anesthetist, and we have an aortic nurse. So all of us sit together and we put, if it is my case, I present my case and I say, this is the CT, but this is his cardiac and this is pulmonary function. Because remember, you're not treating a CT scan. Then the MDT suggests whether the patient is suitable for aneurysm repair. If he is, whether he should have open or whether he should have EVAR. Now, over the years, we have learned the lesson which is re-emphasized, that if the patient is okay for an open, he has an open repair. If however, he has an EVAR, if the anatomy is very straightforward, if the patient is older, or if he's had a scarred abdomen, if he's had previous laparotomies or an intra-abdominal infection, you expect a lot of adhesions in there, then we do consider them for an EVAR. And therein comes experience, because if you have a low volume center, if you don't have the necessary personnel to do the operation, you can get yourself in a lot of trouble. And once you start getting yourself in trouble with aortas, it is very difficult to give the patient a satisfactory outcome. With EVARs, the patient should be ready for lifelong follow-up, because these grafts do run into problems at some stage or the other. So like I said, CT scans, ultrasound, and X-rays is what we use. Next, please. This is the entire arsenal of grafts that we have in Doncaster. We started with Cook. We used to use Cook device for all our aneurysms. Soon we learned that it is not one size that fits all. Various grafts have various strengths. So we now have the Cook Zenith, we have the fenestrated Cook, then we have Incraft from Cordis, we have Lombard AOFix, we have AFX for Endologics, we have Altura, and there's a more recent one that's come on the market. All these grafts, I won't go into the details, they provide the little bit of extra benefit if the patient needs it. And a simple example is the Cook has a suprarenal fixator. It's a very rigid graft, but it has long-term results. We know the graft is good, so we use it if it is a very straightforward, straight aorta. The AOFix is a very conformable graft. If it is a tortuous anatomy, if the neck is slightly angulated, if the iliacs are angulated, that graft works very well. So we have devices. The Altura is a very recent addition. You need 2 surgeons to do it. It is essentially putting 2 devices from 2 groins, parking it on just below the renal and deploying it. It's like 2 stent grafts coming down. It's a nice graft, but it requires 2 surgeons. So the reason I've put this up is for you to show, again, you need specialist input who have a lot of experience, and ideally in big volume centers. Next, please. So in Doncaster, we retrospectively analyzed all our work. We looked at it only for the last 10 years because prior to that, graft technology was evolving and so was our experience. 182 EVARs we looked at, 26 were lost to surgical follow-up. And all the aneurysms that were selected for review were standard infrarenal. We didn't look at our fenestrated or any of that. We looked at the operative results, our MDT files, anesthetic files, We reviewed their images, collected mortality data, and then did a statistical analysis. Next, please. So from demographics, a patient ranged between 50 and 92 years of age. If the 92-year-old patient has good exercise tolerance, good quality of life, and his parameters are all fine, we operate on them. In fact, there's a 91-year-old who's being worked up for surgery, and I'm very scared, but in the next couple of weeks, I'll have to operate on him. So males were, Sid, go back to the previous one, please. Previous slide. Previous slide. So thanks. Males were, the vast majority were males. The average size was about 6.08. We operate only above 5.5 centimeters. The 4.2 that we have was rapid expansion or some symptoms. They sometimes throw off emboli to the leg or something, then you have to consider them for surgery, even if they are small aneurysms. The median size of 5.9. You can see the ASA grades between ASA 1 to 3. The vast majority were ASA 2, but ASA 3 were 19%. And patients had COPD, diabetes, CKD, ischemic heart disease, and the usual. They never come, the aortic patients never come as perfectly fit patients. They always have vascular disease in other beds. Next, please. So at 30 days, within the 30 days, we lost one patient. So 0.5% in the 30-day period was our mortality for EVARs. Overall, in our study period, follow-up period, we had 41 deaths. So over the 10-year period, 22.5 patients died. And this is not unexpected for aortic surgery because, like I said, they have other comorbidities. So if you look at it, the 2-year mortality was 8.7%. However, aneurysm-related death, which is directly related to the aneurysm, was only the one patient, and which is at 0.5%. Next, please. This is very important. The overall re-intervention rate was 10%. So patients who had this surgery, it wasn't done and dusted. 10% had to come back to have something else done. Although the initial procedure was sound, everything was happy. This is where open surgery wins, because once you do it well, patient goes home. It is very unlikely that you'll see the patient. But EVAR, that's not the case. I want to talk to you briefly about endoleaks. If you see the picture below there are different types of endoleaks. There is an endoleak called type 1, where the seal around the renal arteries is not good and blood leaks from the side. That's not good because now what you have previously in an aneurysm, you had blood going through it and coming out. So there's no pressure. When you have endoleak, everywhere else is closed, but blood is coming in. It's like having a balloon where blood going in, but nowhere else to go. So that causes more pressure and the risk of rupture. That's type 1 endoleak. Then you have type 2 and it goes on to type 4. But in essence, you can have leaks at the bottom. You can have leaks at the seal zones where the iliac limb is attached, or the graft itself can fail and you can have leaks through the body of the graft. The fabric material wears out and you can have that. So those are the types of endoleaks that you get. The worry, always beware if after an EVAR, the aneurysm sac is expanding. It should stop expanding or shrink. But if it continues to expand, you can have, that means that there is an endoleak which you are not recognizing, and you have to do an angiogram, you have to investigate the patient thoroughly, because this can lead to sac rupture. This was the mortality that we had within the 30 days. The patient had an endoleak, had a sac rupture, and we had a patient with a sac rupture. He did not die, but we got him in time and we had to operate on him and we had to sew off the endoleak. We had one complete graft occlusion, the entire graft thrombosed, and sadly that was the patient who died. And next, please. We are seeing increasing numbers of this where grafts become thrombosed. The various interventions that we did were we embolized certain lumbars because they were causing continuous bleeding into the sac and sac expansion. proximal extension, where I told you you can have the endoleak from the top. So you have to put another cuffed graft around it to seal that. Then sometimes that does not do it. So we've gone in, operated on them and put a tape around it and tied it so that it closes that aortic wall against the sac. Then we had distal extension where the iliacs, there's leaking around the iliacs. So we had to put grafts around the iliacs. Sometimes, although you try your best not to cover the renal arteries, do get sometimes covered a little bit. So they required stenting to keep them open. These grafts can be thrombogenic, and we have a series which we are hoping to publish soon that for no good reason, the limbs occlude. So there is a theory that these patients are thrombogenic or that they are allergic to some of the metal in the graft. So we've had to do thrombectomies. Other revascularization where they have got developed sigmoid ischemia and so on, they require. Very rarely do we need the patients bleed or there is a problem intraoperatively and they need to be converted to open repair. So we've had 21 re-interventions in our series. Next, please. So I think overall our results compared very favorably with the good centers in literature. All our re-intervention to our complication to our death rates compare very favorably, in fact are better in some places than most centers. But what we've learned over time is that one graft does not suit all. Open repair wherever possible. And it is not unreasonable. Remember, this is a prophylactic surgery. You're treating patients so that the aneurysm does not rupture. So you need to consider if the patient is really old or if he's unfit, don't take an EVAR to him because he may live longer than the rupture rate of the aneurysm. So use your device and choose your patient very carefully. Next, please. So that is our take-home message, and I cannot overemphasize more the importance of a vascular surgeon. Always seek their help and guidance whenever you should need to. Thank you very much for the opportunity. I'm happy to take questions.
Thank you, Nandan. Before we go into discussion, actually, we would thank Medtronic, our principal sponsors today. In this part of the world, we most often end up using Medtronic device rather than Cook device anyway. So just 2 questions in chat box before we go into the discussion formally. Someone is asking about the radiation exposure in an EVAR.
Yeah, it is, the radiation exposure from an EVAR is significant. And I cannot tell you the exact rads, but we do document it. And there are several things that you can do to reduce the radiation exposure. So if for those of you, you keep your patient really close to your image intensifier. So you reduce the scatter. You obviously have to wear lead and all of that. And then with experience, what we've learned is we only do 2 angio runs. We don't continuously do angio runs because the single shot that we take just to see the position of the graft is not heavy in, it's the angio runs that we do are very heavy on radiation. So keep those to a minimum. So what we do is we put our device in, we take, with EVAR, one of the things that I should tell you is probably pre-operative planning is more important than intraoperative operating. So I would we plan our own EVARs. We don't give it out to the radiologist or to the company. We plan our own EVARs and you need good software to plan it. You spend an hour planning it and you think about where the graft is going to sit, how it is going to sit intraoperatively. And we have a sheet of all the planning. And that sheet is continuously evolving over time as we pick up things. And once we do that, we put the device in, we take a run when we are ready to deploy. That's the only contrast run we do. Then we're happy, we deploy the device. And after that, we do the one contrast run for the iliacs to position the iliacs. And in the end, you have to do a contrast run where you can stand really far from the patient just for completion to make sure that there are no endoleaks. There is a risk, there is a high dose of radiation, but there are various ways you can minimize it. Post-operatively, the patient has to again have radiation, and that's one of the reasons why young patients, you don't do EVARs, because through their lifetime, they will need CT scans and they will need angios and things like that. So there is a paper to show that patients, young patients who undergo EVARs, there's a slightly higher risk of malignancy. So young patients consider open repair, and very important, if you become a vascular surgeon, make sure that you protect yourself well.
Okay, and then another question is, which is the best site for puncture in endo, right or left? Or do you go by CT scan?
Okay, there is no good right or left side. No. Very important. There are two aspects to this, to puncture. The first is, in planning, you need to look at the CT scan, and remember, if you look at the device itself, the main body is the larger device. It's the more bulky device. That goes through the straighter iliac. Okay. The second thing is calcification of iliacs, caliber of iliacs. So you choose the better iliac generally for the main body. The iliac limbs, you can push them through the lesser friendly iliac. And for puncture itself, if you're doing percutaneous, it's very, very important to do ultrasound. Puncture on the common femoral in a good place, not on the side, anteriorly, because you'll use closure devices anteriorly. So the puncture should be accurately placed right in the middle of the vessel. And I would not recommend, it's completely based on the morphology of the iliacs and the state of the iliacs that you pick.
Okay, next is about the follow-up. What is the follow-up protocol for open surgery, RC?
Once a patient is discharged, then you can ask them to have I usually see them after 6 weeks. Then I put them a 3 months follow-up, the first 2 years, then 6 monthly or 1 year, depending on the patient's condition. And most of the long-term patients, they meet me once in a year. I'll just do a Doppler or look at the peripheral pulses, see the pulse are normal, okay. And I will do a Doppler of the ultrasound of the abdomen, just look at any leaks or something like that. So that's what I'm doing it. Rarely will I do a CT scan after 3-4 years.
What's the protocol for endo in UK? What's the protocol, and then follow-up protocol after EVAR?
So after EVAR, before discharge, we get an abdominal X-ray. The abdominal X-ray is triplanar. So you get front and lateral views. So you can see it in all dimensions. And once we get that, then at 3 months, they have a CT scan with abdominal X-rays again. And the CT scan is a contrast CT. If all is well after that, at 6 months, they'll have abdominal X-ray with ultrasound. And ultrasound, it's very important to scan the iliacs as well to see flow in the iliacs. Because if the iliac flow is not good, you know there is an iliac limb problem. And if that is good, 1 yearly abdominal X-ray and ultrasound. If that is good, yearly abdominal X-ray and ultrasound for life. If there is a problem detected at any stage, that is sac expansion, poor flow in the iliacs, or any problem, the next port of call is a CT scan, contrast CT. If the CT scan shows endoleak, we localize it with an angiogram and then plan treatment accordingly. Can I just add to Sri Kumar?
Yes, please.
Yeah, sure.
Sri, with open abdominal surgery, we see them at about 3 months. If we are well, we discharge them.
No, I discharge them after 7 or 8 days.
No, not immediately post-op. I'm saying in clinic, 3 months after surgery, they get
no long-term follow-up is required for open surgery. That's what he's saying.
Yeah.
Yes.
And the important thing, what Sri mentioned, is very important. If you have an abdominal aortic aneurysm for the PGs, remember you could have popliteal aneurysms and peripheral aneurysms. So when you see them at follow-up, make sure that they don't, or we do it pre-op, make sure that they have no peripheral aneurysms. That's very important.
Very important. But then our incidence of peripheral aneurysm is comparatively less comparing to you people. Maybe the factors will be there, but rarely only we see peripheral aneurysms in aortic aneurysm patients.
Right.
Maybe once in 3 months, 6 months, one case.
Okay, before I move to next question, there's a quiz on the chat box. Please try to answer that. Those who answer first stand a chance of getting 5,000 rupees. Okay, next question. And then the question is, what is the antiplatelet protocol after open repair and EVAR?
After open repair, aspirin, statin. That's it. Or clopidogrel and a statin. Following EVAR, absolutely the same. Aspirin or clopidogrel with a statin. That's the antiplatelet requirement. And if they develop any graft thrombosis, or sometimes these patients develop, when you see the first CT scan, there's a little thrombus sitting, which we don't like, then we consider anticoagulation for 6 months. But otherwise, it's only aspirin or statin, aspirin, clopidogrel, or statin.
What anticoagulation do you prefer? Like nowadays, because of
Nowadays we use rivaroxaban.
Okay.
That's
Nandan, are you happy with the rivaroxaban, or you have any complications?
We've not had major complications, but we've seen some failures, Sri Kumar. Despite rivaroxaban, they've had problems, but that equally we've seen with warfarin also. So what we generally tend to do is we put them on rivaroxaban, and there is a great trial recently with the COMPASS study. So a lot of them now we're doing low dose rivaroxaban with aspirin. And we've also been slightly maybe brave that we've given them full rivaroxaban or full apixaban with aspirin. And we just warn them that there is a risk of a fatal bleed and to be careful, but we've done it without any problem so far.
Post-EVAR, your dose is 2.5 or 20 mg?
Post-EVAR, we routinely don't give rivaroxaban. We just give aspirin or a statin. Only if we have any suspicion of a thrombus at our 3-week CT scan, or if there is a kink in the graft that we are worried about, or some rare thing like that, then we give them rivaroxaban, but we give full dose.
Okay, fine.
Okay, another question is about stent explantation. I think probably Kason sir is the best person to answer the question. How easy or how difficult is it to explant the stent graft if you had to do an open surgery after EVAR? Kason
I
sir.
think it is going to be really a tough thing, because you will have to, the stent graft will be very close to the renal arteries. So if you have to take it out, probably you have to do the grafting, and you have to revascularize the renal vessels. So it's going to be really tough. Luckily, I didn't have to do that. Some of the failure of the EVARs, we managed with another repeat EVAR. So I have not had any misfortune of doing it. So it's going to be really a tough decision. We may have to convert it into probably a thoracoabdominal aneurysm and reimplant all the branches.
Okay. Any tips, Nandan from UK? Yeah.
I can only say sir's experience. Sir, I completely agree with you. If you are close to retirement, you retire and give that patient to somebody else. We've had 3. I've participated in 3 explantations. So, and if you do EVARs long enough, you will have this problem. So what you tend to do is, like I told you in the graph, they have suprarenal fixators. So if you do everything like you do prepare for open surgery, clamp above the renals, clamp above the renals, iliacs, open the sac. When you open the sac, if you try to explant the device, you're in big trouble, because the barbs are well embedded, and it also forms a lining, like an endothelial lining. So if you pull it out, you will tear everything and there'll be nothing left to stitch. I've been there once. Luckily, I was the registrar and the consultant was the one who was in trouble. But so if you want to do it, what you do is you put a syringe inside and the device opens. Like if you think about the device opening, you can see it on YouTube. There are things how it opens up like that and goes and sits down. The barbs sit like that. So what you have to do is put a syringe inside, push the graft up. So it disengages the barbs. When you push it up, you collapse the graft around the syringe, put a tie around it so it stays collapsed, and then you pull out. I hope I'm explaining it properly. So you disengage the grafts on a syringe, then push it up higher into the aorta, then you tie it around the syringe so it stays collapsed because it's quite rigid. And then you tie it there and then gently pull it out. But The next technique is the suprarenal barbs are there, but you don't have to worry about it. So put your suprarenal clamp, just use a cutter and cut it. Cut all the barbs out. And once you cut the barbs out, stitch your graft in the presence of the barbs to the aorta. So you're not disrupting any of the aorta, and get out of there. The trick is do the minimal, get out of there as soon as you can, because you start thinking that you're making good progress and you say, oh, well, I'll take this graft out or anything like that. I'll guarantee you, you'll get into trouble. So the three that we've done, one, we tried to pull out the graft, the aorta tore in several places, but somehow we managed it. After that, we now just cut the barbs and stitch onto it with a suprarenal clamp.
Okay, RC,
Recently,
your experience, RC, your experience.
I had removed only one virus in Chitra, but that is little below the renal artery. So we have divided the aorta. A segment is totally divided. Then I put a end-to-end anastomose with a graft. So I'm lucky that renal arteries are not involved. That's the only experience I had. But recently, Shiva has done an arch aneurysm stent explantation. Shiva, are you there? Shiva?
Yes, sir. Yes, I am there, sir.
Shiva has done a heroic removal of a stent graft.
It was done under circulatory arrest. So we arrested, total circulatory arrest was done. We opened the aorta and then removed it. It didn't have any barb, so it easily came out, sir. It was infected TEVAR, so without barb, so it easily came out.
I think, Undi sir, do you want to add to that explanation of the EVAR device, sir?
In fact, I have had only experience with 2 patients done outside. And the indication was type 1 endoleak. So it was not very difficult to disengage the graft. So one of them survived, one of them died. So that died patient had some paraparesis, not like paraplegia, but then we could shift him to the primary physician who has done, a cardiologist. So basically I feel many times clamping suprarenal may be difficult. I would prefer a hiatal clamp. Just get the graft, top end of the graft and come down to the infrarenal aorta. That I think in my view, that is what we have done in one case. And that one case where we were clamping below infrarenal only, then what happened was the graft could not be, the stent graft could not easily come out. So I realized, I think there are techniques would describe suprarenal or supraceliac clamp so that you have far away from the explanted graft. And many times if it's type A or especially type 1A and only, the graft is not fixed so much. It will be a bit of loose thing and it can come out. In fact, I was listening only half of RC's presentation. Very good session on aortic, abdominal aortic aneurysm. Thanks, Nandan. Nice to meet you and then listen from you. I quite agree. The EVAR may look very pleasant, maybe with a mortality of 1%, open about 3 to 3.5. But I think the burden of surveillance and reinterventions are high. And the patient getting blood dyscrasia is high because of repeated CTs which they need. So it's a little bit of a nuisance value that the problem continues one way or other. So in my own experience, I have done 364 open surgeries and 20 EVARs. Fortunately, in that 20, nobody required any, not much, only one graft limb was occluded. We had to do an angioplasty because there was some stenosis. And through the graft, the radiologist did the angioplasty. Otherwise, I don't know of any major problem with the EVARs because the numbers are very small. And as Dr. Nilanandan is there with us, from our training time, it was only open surgery and the EVARs came much later. So we got into big love with open surgery and money and the cost factor was so much that, we were not in the initial time, we never did. But 2007, we started some selected patients EVAR. But on the contrary, we used more of TEVARs and arch hybrids in the thoracic segment. So abdominal aorta, it has never been a favorite unless the patient has got, say, 80 plus age or they're unhealthy, they've got a hostile abdomen and patient preference. So we opted for open nearly all the way, EVAR extremely selective patients. And thank you, Nandan, having present with us today evening.
Pleasure, sir. Pleasure.
And then one more last question, chat box. That's about endo leak. It's a huge topic, I know, but can you just summarize about management of endo leaks just in a few minutes?
Yeah. So endo leaks, malignant and non-malignant. Malignant endo leaks are where they can cause problems with usually sac rupture. So if you have a type 1 endo leak, which is at the top, or if you have an endo leak from the below near the iliac iliacs, where the iliacs are meant to attach to the artery, or junction where the two grafts sit between each other. If you have not overlapped them enough, if there's a gap or the art is slipped, you get an endo leak, or the fabric tears, you have endo leaks. Now, the management of each endo leak differs. One of the commonest endo leaks that we have seen is because of something called sac effacement. So what happens with the aneurysm is, it is very important in EVARs to have a good neck. I should have mentioned that in my talk. If you don't have a 1.5 centimeter neck, and if you have a small neck and you force an EVAR, or if the neck is bulbous, conical, you do an EVAR, you can predict that if this patient lives beyond 7-8 years, he'll have an endo leak, he'll come back. So what happens is, these aneurysms grow slightly. The EVAR device is oversized. So we oversize the EVAR device. So initially that keeps up for some time, after which blood flows through. When you have that kind of scenario where the neck has effaced and you have endo leak, your options are limited. If the patient is fit, you'd have to do open surgery for them. If the patient is unfit, what you can attempt is, you put the EVAR stent has good radial force, but it is still flexible. So what you do is you put a stent from below called PAMAS, which has very good radial force. So the PAMAS stent opens up, pushes the EVAR device further into the wall, and thereby stopping the endo leak. We've also used something called endo anchors. So these are devices that go up into the stent graft, and you can turn the device. You push it against the stent graft and the abdominal wall, and then it puts screws inside that and adheres it. So I've done one case of that, and luckily it solved the endo leak. So you put at various positions in the clock face, you put screws and fix the fabric on the side. Those are for your top. If it is for the bottom, if your iliacs have effaced, that is, your iliacs have grown too big, then sometimes what you have to do is you have to sacrifice one internal iliac. So we put a device and embolize the internal, and put another stent graft from the common into the external iliac. One internal iliac is enough for the patient if the contralateral internal is good. That is one way of doing it. If you have a graft porous material, then what you can do is you can put another EVAR inside the EVAR to seal it off. But you got to remember that the iliac dimensions are not huge. So you have sometimes 1 centimeter. If you put another device in, that gets reduced to 7 cents. So these patients can be at the increased risk of limb occlusions. So these are the way. Then we've used something called onyx. It's a very expensive material. So if you have type 2 endo leaks where the lumbar arteries are feeding into the sac and it continues to increase, type 2 endo leaks we generally ignore unless the sac is increasing. If it is increasing, then you go and embolize the lumbars. If that doesn't work, we directly puncture the sac under image intensifiers, and we inject this material called onyx. Onyx solidifies and seals off. Once there is no space for the blood to come, it thromboses that vessel that's bleeding into it and blocks it off. So those are in short, those are how we treat endo leaks.
Neelandan sir, any general comments on the whole topic? Anything else you want to add to the whole discussion?
Yeah, especially for the listeners, the general surgeons and other physicians who are attending, some of the points they have to remember is more than 50% of the abdominal aortic aneurysms patients are asymptomatic. So many patients say, I don't have any pain, then why should I get treated? But many a time, the first time they get a pain, it is because of the rupture. So just because the patient is asymptomatic, you have to tell them that It is the rupture which we want to avoid, and even asymptomatic patients with a size of 5 to 5.5 centimeters should get intervention. Secondly, CT angiogram is the best mode of investigation, unless there is some contraindication like creatinine. So I always prefer CT angiogram. If that is not possible, we may have to do a plain CT or MRI for the confirmation and planning of the case. Then thirdly, the type of treatment. In a fit patient, open surgery is the treatment of choice. But if there are some contraindication like age or other comorbidities, then we have to subject them to endovascular procedure. And in our country, where money is a big problem, I think any patient should be advised on open surgery. If not possible, we have to subject them to endovascular procedure. I think that's all the major points I have to mention here.
Any other comments or questions from the other speakers or audience want to add to?
Sunil, can I ask one question? I'm Dr. Rajesh here.
Sure.
What's the general consensus of the graphs that we use? Because we use Dacron graphs as well as PTFE graphs for these procedures. So in the long-term experience, which one would be the ideal one to use? We generally use Dacron graphs. Just like to know from the senior faculty also. Thank you.
RC, can you?
Rajesh, that's a good question. But for the aortic aneurysm, the common consensus is more in favor of Dacron. Maybe Kaladan Dacron is the preferred one used now, but a plain Dacron also. And long-term results of Dacron on aortic aneurysm is excellent. We don't see not much complications using Dacron. In fact, from my experience, I would say PTF is inferior to Dacron for aortic aneurysm repair because it may produce suture bleed, little complications. So for me and for the literature, Dacron is a preferred graft for the aortic aneurysm repair.
Thank you.
I have one question to Nandan. Institutionally, do you have a AAA screening program, or do you insist on a AAA? Because in our country, we just beginning to have institutional, not countrywide population studies is impossible. So what is your opinion? How much you concentrate? What is your yield from screening tests?
We are the regional center for South Yorkshire for screening. We won the bid to screen the population. So we lead on the screening. The initial studies for screening showed that they were very cost effective to screen the population because I think Shri mentioned it. An aortic aneurysm, although it is an asymptomatic condition, is as bad as having late stage cancer. So, and cost effective wise, it is better for the patient to treat aneurysm than to treat cancer. If you take it as just as a cost effectiveness.
Right.
So screening studies showed that it was very useful, but in reality, when we did the screening, the yield hasn't been that great. That may be a reflection because people in the West have reduced smoking, reduced incidence of smoking. They're leading fitter and healthier lifestyle. So it may be a multifactorial, but it has not been as lucrative as it showed in the pilot studies for screening. But one of the practical points is when you have a patient with an abdominal aortic aneurysm or any aneurysm, Indian population, because it is a condition mostly of the West, you should always make sure the family, the children or the siblings are screened because there is very good evidence to show it is a familial condition. And if your father has it, there's a chance you could have it or your children could have it. So it is a good idea for the rest of the family, usually at the age of about 50, to have a one-off ultrasound scan. You should advise your patients to do that.
No, because we never had a sound screening system, even in Trivandrum or nowhere in India. And the literature says 0.3 to 0.6% is the take for 5.5. That is large size to just go in. Otherwise, you get only small aneurysms. So,
yeah, the 2 points are there. One is it's good to get a small aneurysm because you can survey it and make sure it doesn't rupture. You can keep an eye on it.
Right.
So that is yield in my view. In my view, but the problem was from the pilot studies to when it was implemented, the yield has dropped.
Yes.
So in today's day and age, if we did a pilot, we probably would not have national screening. And if you extrapolate that to the Indian subcontinent where aneurysms are even rarer, so I don't think it would be cost effective in India to screen the population. But I think for the PGs and the other vascular surgeons, I would strongly recommend if you pick up an aneurysm, just tell the rest of the family, especially male members, to get a one-off ultrasound, cheap, and that will make sure that they are not hiding aneurysms.
But at this point, Nandan, in our institution, I think Dr. Nilayandan would really know and can support. We have never had an elderly person's son screened or operated, not even one family. So I quite agree with you. Incidence of most vascular diseases are rare in India. And so screening in population base is not possible. What we are going to do as VSI is, for those patients who have carotid disease or peripheral artery disease, we screen. Anybody above 65 years with diabetic, smoking and hypertension, we screen an individual institutional wise and see the result. That seems more practical with us.
Nandan, can I make a point? Because now the aging population in India, especially Kerala, is too little more than the rest of India. And we see more of aneurysms in Kerala because we get more of aged population. So by the time we get more aged population, we might get into more of aneurysm repairs in general. So the scenario may not be different from UK and Kerala, might be almost the same. Okay, I think we have Shivanesan here, who is the head of Department of Srichitra. Now, Shivanesan, would you like to add something to the whole discussion? Shivanesan? I think he's not there. Okay, so
Can I make one point to the PGs?
Yes, sure.
If you do vascular surgery, one of the very, very useful skills is ultrasound. And it's very easy to learn, it's very easy to master. So learn ultrasound skills. There are very cheap portable ultrasound scans that you can carry. Once you get used to it, it becomes like a stethoscope for the vascular surgeon. And if you have that, then if you have your carotid, it's very easy to screen, check he has no aneurysm. In a hospital not so far from us, there's a patient who had a very successful carotid endarterectomy, went home, 4 days later came back dead because nobody had felt his abdomen. He had had a 10 centimeter abdominal aortic aneurysm. So it looks very bad if especially a vascular surgeon does not feel an abdomen and misses an aneurysm. So I would strongly recommend right from the beginning, get a cheap ultrasound scanner and practice your scanning skills.
Good point.
So I think the bottom line of discussion is that we have to balance open surgery with EVAR when you offer the patient an option, because we have to tell them the risk and benefit of both procedures, obviously, and younger patients should be offered open surgery if possible. And I think vascular surgeons should lead the aneurysm program, because we can offer patient both the treatment modalities equally well, and we can give a more unbiased option to the patient basically. I think that is the gist of the whole discussion. Both are good treatment, but you should make the right choice in the right patient at the right time. I think Siddharth, who is coordinating the whole webinar series as such, can just say a few words of vote of thanks or something, just to complete the formality. Siddharth.
Yes, sir. So first of all, thank you, Neelakandan sir, for. Yeah. Hello, am I audible?
Yeah, you're audible. Yeah.
So thank you, Neelakandan sir, for being here today. Your presence has been like a godfather appearance to us and made this presentation complete. Uni sir, for your presence as well. And special thanks to Mr. Haldipur sir for being present from UK and giving us a very good overview about EVAR, and our R.C. Srikumar sir and Dr. Chandrasekharan sir for their inputs on basic management of EVAR and on abdominal aneurysms and the open surgical technique. So we also again thank our session sponsors for today, Medtronic, for supporting us. And at the end of it, I would like to thank all our participants who have come and joined us for this discussion, and I hope you have taken some good take-home messages from this meeting. So I'd like to also invite all of you to the next talk, which will be on the 23rd. It is also on aortic aneurysms, but this time we'll focus on the thoracic aorta. So it'll be on thoracic aortic aneurysms and dissections, and this will be held on the 23rd of January. So I welcome all of you to attend that session as well. So thank you once again, and a good night to all of you, and see you in 2 weeks. Thank you.
Thank you, Siddharth. Good job.
Sid,
Thank-
well coordinated, yeah.
And of course, thanks to Sunil sir as well for the excellent moderation. Thank you, sir.
This is the first time Sri Kumar, Sunil, they are sitting through a meeting, finishing the meeting and no whiskey at the end of it. And I could see Sunil. Sunil has a glass by his side.
Sri Kumar is sober now, boss.
Sri Kumar, that can't happen, yeah. What do you mean? You Sri Kumar and sober. Sunil, any comments on that?
No, we are coming back in a minute. Don't worry. Okay, Nanda, it was nice. Nice. Actually, Zoom has actually made things more easier than before, no?
Yeah, exactly. Sri Kumar.
Sitting far, we are near. Sitting far, we are near. And inform our regards to Willis and Seva Singh.
Going back to us, the same. I'll stop this now. And
Okay, sir. See you then.
Okay, see you.
no, I'm ending the meeting now. And I'm going to restart it. So others are not there. Myself, you, Sunil, Siddharth,